Hear me? Okay, thank you very much, Argeris, for the invitation. The third part is about the spontaneous pneumothorax and about the ambulatory or the thoracoscopic management. Dr. Emmanuel will talk about the ambulatory management of the spontaneous pneumothorax. The floor is yours, Philip.
So thank you. It's indeed an honor to be here. I will try to be brief because we are a little bit off time, but I will try in a few minutes with a few slides to persuade you that we pulmonologists are very useful in treating the pleura as well, not only the lung nodules, and or taking biopsies as regards interstitial diseases. So the debate is spontaneous pneumothorax, ambulatory or thoracoscopic management. I will give you the pulmonologist view, and indeed searching the literature, I did not find any conflict between pulmonologists and thoracic surgeons. Primary spontaneous pneumothorax happens to patients which are usually young, smokers, especially if they are cannabis users, and it has a significant recurrence rate. So it's an important clinical entity, and we must focus, and we have to have it in mind. It is associated with low rates of morbidity or mortality. So tension pneumothorax is not a very common case in these patients, but the recurrence rate can reach up to 50%. So it is something that we must be aware. The treatment is usually guided from the symptoms rather than the pneumothorax size. And I will show you in a few slides what I mean. In order for us to have guidance on this, there are very recent guidelines which we must follow. It's from the British Thoracic Society and the ERS, and these are readily available for you to assess and start building confidence on treating primary spontaneous pneumothorax. There is a complex pathophysiology. There are some blebs and bullae which are found in these patients when we do biopsies, when we do surgery and we take parts of the lung off. Now they're called emphysema-like changes, ELC, and they're recognized as a specific entity. Indeed, it has been found that in these young patients, the recurrence of pneumothorax is due to an increased porosity of the pleura. So there are connections and there's air going into the pleura. But when we remove these bullae, it is sometimes these patients remain prone to recurrence. So the role of these bullae and blebs is non-specific. It's not clear. So now going to treatment, we are used to guide our treatment with the size of pneumothorax. You can see here a pneumothorax which is quite small. In order to correctly assess the level of the pneumothorax, we usually go to the hilar region, and then we calculate if it is more than 2 centimeters. And of course, the CT scan is usually more accurate than our chest X-ray. The size of the pneumothorax determines the rate of resolution, but remains a relative indication for active intervention. So how can the pulmonologist assist to the care of PSP? First of all, usually we are the first clinicians that come and assess the case. We have a patient that has chest pain and dyspnea, so we are the first person of contact. After doing the regular imaging, if we are in emergency setting and things are chaotic, we usually can be trained in doing lung ultrasound. And you can see here a very good example of how the normal lung looks when we probe at the intercostal level with this abdominal probe. We see that the lung is sliding between the visceral and the parietal pleura. So when we see this sign of this lung sliding, we are sure that there is no pneumothorax. When air intervenes between the parietal and the visceral pleura, it seems that this lung sliding is lost. So we can be more sure that we have a pneumothorax. Of course, this method is complementary to our other imaging. Now, what if we decide to go for conservative management? It is true that the guidelines and in general, in the recent years, we have a switch to the conservative approach, and intrapleural error doesn't necessarily cause a problem in these patients. So in most of them, we can actually wait. The conservative approach is quite understandable because tension pneumothorax in PSP is quite rare. So we don't know the risk of having a patient with a lot of dyspnea, with hemodynamic collapse, etc. So the British Thoracic Society guidelines are much more conservative in their approach. The management depends on, and it's based on clinical symptoms. Whereas older guidelines, such as ACCP guidelines, do not give any, do not have any respect for the symptoms, and it really depends on whether you have a pneumothorax that covers the 20% of the hemithorax, irrespective of symptoms. And of course, if we decide to treat a pneumothorax, it means that we have a patient that has a 2-centimeter margin and he has dyspnea, he's symptomatic. We must decide whether we will just put a needle aspiration or have our thoracic surgeon put a chest drain. And also we have to decide about which size of chest drain we must apply. So there is a difference also between BTS newer guidelines and the ACCP older guidelines. BTS suggests aspiration as an initial intervention in patients with a larger symptomatic primary pneumothorax, where ACCP guidelines, which are older, do not recommend this approach. Indeed, randomized trials suggest that needle aspiration is effective for the initial management of spontaneous pneumothorax. And also, it goes to the next step. If the pneumothorax is aspirated and patients feel well, we can discharge them and not keep them for observation in the hospital. Also, the same results we can have for patients that we expect that they will not be treated immediately, so we can put a very, very small tube and even discharge them with a Heimlich valve, which is also useful in these cases, but not routinely used here in Greece. So you see here some studies, comparative, and there are two studies here which are quite older that even have an advantage as regards days in hospital and admissions when we use the simple aspiration technique. And of course, for all studies, if we use the larger chest tubes or we use the aspiration, there were not significant differences. So we can consider using this simple aspiration technique, and this is comprised of the following. We go to the second intercostal rib in the median intercostal line. We apply lidocaine so the patient will not have any pain. And we use these simple catheters, which are intravenous peripheral catheters. And we can, I'll show you a simple video. Unfortunately, it doesn't play. Okay. So we have water, a water seal, and we reach into the thorax in order to assess whether we have bubbles, so if we have air. And when we take off the air, we are able, as you see here, we are able then to introduce a small catheter and use a three-way valve in order to evacuate all air with a 60 ml syringe. And if necessary, if it is something persisting, we can connect this to a water seal. Also, we can use larger tubes, usually because these simple peripheral catheter lines are not very stable. We usually use the central venous catheter, which uses a Seldinger technique, and which are very small, 11 to 13 French, and we can perform really better than the larger drains because these cause significantly more discomfort and pain. And also we can, if we want to discharge the patient and we feel that he's safe, we can use also this Heimlich valve, as I showed you, and it has been shown that this is a very effective technique. So this is the second technique, the Seldinger technique, and you can use various sizes if we have air or fluid, of course, because this can be used for the pleural fluid. We puncture, and we introduce the guide wire, then we remove the needle, and we do a stub incision and dilate the entry side, so we will be able to introduce our catheter. Then we pass the catheter through the guide wire, and then the only tricky part is that we have to push the catheter very closely and very vertically to the skin in order not to have the guide wire messed up. So then when we have introduced it and we have aspirated air, we can stabilize and suture the catheter in place, and we can even connect it to a water seal and leave it there for 24 or 48 hours. So this is a very useful technique to use also in primary spontaneous pneumothorax, but also secondary pneumothorax or pleural effusions as well. A very nice device, which unfortunately is a little bit expensive. It is very readily used in the UK, but not in Greece at the moment, is this rocket pleural vent. This has the novelty that, unfortunately, the video here doesn't play, but this has the novelty that needs no water seal. It can be left in place on the patient for several days, just like this, because it has this relevant valve, as you see here. And so we don't need any water seal. We don't need the patient in the hospital. We just apply this. We take off the needle. This doesn't need to be sutured. It's just placed on the thorax, on the second intercostal space, and we can leave it for several days in order for the air to be evacuated, even if we have a small loss of air. There has been a very big study, the RAMP trial, which has randomized either to use this technique or the standard BTS technique, and it has been shown that it has reduced significantly the hospital stay, but also the comfort of the patient. So it's a very useful technique. It's very good for using in an emergency unit, but unfortunately it comes with a higher cost as regards a central venous catheter. So a newer study, simple aspiration, also again versus drainage for complete pneumothorax, also the same results. There are relapses. If we don't use a big chest tube drain, there are relapses to the pneumothorax due to air leak, but for sure the patients feel less discomfort and are more readily discharged from the hospital or even from the emergency unit. So this, all these studies and all this debate has led to a very nice editorial by Gary Lee, a pleural physician based in Australia, who is considered an expert in this field, and says that even though we have all these nice techniques that we can use in the emergency units as pulmonologists, unfortunately we have a bias, and we prefer to call the thoracic surgeon in order for him to put a big tube, but we are not evaluating this correctly because small tubes and aspirations can lead to less discomfort for our patients. Of course, he mentions that this comes at an increased relapse rate. So there are cases where our thoracic surgeon is indispensable. I will shortly show you this from the BTS. So we have this nice algorithm. I have 2 slides only. So here we have the PSP, but also to bring you back to our talk for the pulmonary nodules, we have to keep in mind that we have secondary pneumothoraxes and also iatrogenic pneumothorax when we do transbronchial biopsies. So this is a very useful technique for people who perform bronchoscopies and transbronchial biopsies. We have to master this because we will not have our thoracic surgeons available for putting big tubes. We must be able to do it ourselves. When we treat more rigorously, putting a chest tube or even going for surgery, when we have a second episode of PSP, when we have persisting air leak for more than 5 days, or when we have people who drive aeroplanes or are divers. So when we have a first case in a diver or a combat pilot, we must consider definite treatment because it can be dangerous if it happens under the sea or in the air. So the best solution that we have is the talc poudrage. Graded talc has been used for pleurodesis in PSP for a long time. It is very safe. The relapse rate is very low. And now we use it a lot through medical thoracoscopy. So trained pulmonologists do medical thoracoscopies under conscious sedation. It is considered the first choice to provide pleurodesis with talc poudrage. And it is a very useful technique because it's conscious sedation, it's uniportal, so we have all our tools through one small hole. Here you see a thoracoscope for medical thoracoscopy of 10 millimeter channel. And of course, it is something that it needs training because, as you see, that the anatomy is completely different than the bronchi, so it has a learning curve. And you can see here, unfortunately, it doesn't play. I had a snowstorm. It was a talc poudrage. It doesn't matter. The important thing is that mastering this technique is possible even for pulmonologists. And in the UK, it is quite common to use the semi-rigid thoracoscope, which has a more similar picture to our bronchoscope, and it is used a lot. So with this is my last slide. When do we refer to thoracic surgeons? In case of persistent air leak, after 3 to 5 days, depending, there is no consensus on that, we call our surgeons, which have also become very clever, and they can do everything uniportally now. So with this, I would like to stress that there is no conflict between us. We will use our surgeon for complicated cases. For simpler cases, we can treat it ourselves. And thank you very much. I think that was quite quick.
Stavros.